High-grade dural arteriovenous fistula with retrograde dural sinus flow and venous hypertension provoking reversible Parkinsonism. Background: Parkinsonism is a clinical syndrome associated with bradykinesia, resting tremor, rigidity, and postural instability. Dural arteriovenous fistulas in themselves are rare occurrences in the population, most being benign, but aggressive dural AVFs can cause pulsatile tinnitus, bruits, headaches, or visual impairment. Although rare, dural AVFs can also lead to Parkinsonian-like symptoms and rapid progressive dementia. It is critical to ensure that an underlying dural AVF is not the cause of Parkinsonian symptoms. Differentiating between a dural arteriovenous fistula and a neurodegenerative disease as a cause of these symptoms is of significant clinical importance due to the reversible nature of dural AVFs once diagnosed and properly treated. Case presentation. Here we present the case of a 75-year-old male with a past medical history significant for hyperlipidemia, TIA, left-sided AVM, who presented to the ED as a stroke alert with the symptoms of confusion, slurred speech, and unsteady gait that acutely worsened prior to arrival. Upon further questioning, the patient's wife admits that he has been having ataxia with a shuffling gait, a resting tremor of the hands, and memory difficulties for approximately the past month. By the time of initial evaluation in the emergency department, all symptoms had resolved. An initial diagnosis of Parkinson's disease was made given the family history of the same. The patient was diagnosed with an AVM at approximately 35 years of age, with an associated bruit prompted further workup. He was told it was benign appearing at that time and did not undergo any treatment. Upon admission, he underwent a diagnostic cerebral angiogram with neurointerventional radiology, which revealed a dural AV fistula with associated left AICA flow-related aneurysm. This resulted in arterialization of the dural sinuses, reversal of flow in the superior and sagittal sinus, and marked venous hypertension in the bilateral anterior and posterior circulations. Due to the aggressive nature of the fistula as well as possible source of his Parkinsonian symptoms, it was recommended that he undergo endovascular occlusion of the AV fistula and coral embolization of the aneurysm. He followed up at a tertiary care center where he underwent the aforementioned procedures without complication. He was in our residency clinic approximately 1 month post-procedure with complete resolution of the Parkinsonian symptoms. Results: physical exam positive for cogwheel rigidity, pertinent imaging, MRA head without contrast, showing saccular 5 mm aneurysm at the left anterior inferior cerebellar artery, left ventral AVM with draining vein to the left transverse sinus, cerebral angiography. There is a Borden type 2B, Cognar type 2A plus B dural AV fistula with multiple fleeting branches, which demonstrates retrograde flow, and a left AICA 4 mm by 4 mm by 3.5 mm flow-related aneurysm. No pertinent positive on initial labs. Imaging shown as below. Discussion: Parkinsonism is an exceptionally rare clinical manifestation of dural arteriovenous malformations. As of 2020, it only appeared in the literature in a few case reports and small case series. Several pathophysiological mechanisms have been proposed, the most prominent of which is venous congestion. The impaired drainage of deep internal veins in a patient with dural AVF leads to cerebral hyperperfusion, specifically the basal ganglia, an area involved in the pathophysiology of Parkinson's. It is likely that the nigrostriatal dysfunction are involved in this very rare presentation in patients with dural AVF. Endovascular embolization is a treatment of choice. When a dural AVF is treated and occluded completely, the syndrome is rapidly reversible without requiring Parkinson drug therapy. Early detection and rapid diagnosis and treatment is important to reverse further neurological and clinical deterioration. Differentiating between Parkinsonism symptoms due to dural AVFs and those induced by neurodegenerative disease should be of significant importance during examination and history taking due to the reversible nature of dural arteriovenous malformations. Conclusion: dural arteriovenous malformations, although most are asymptomatic and benign, can become aggressive and lead to a myriad of symptoms. These symptoms may include Parkinsonian symptoms such as shuffling gait, tremor, and memory disturbance in rare circumstances. Identification of such a cause is of critical importance due to the reversible nature once the AVF is treated. Thank you.